Good evening, everyone. Thanks for tuning in on this fairly sunny Monday. Today we're going to be covering SBAs in dermatology. So basically the premise of the session is going to be running through some common SBAs that come up in your exams, particularly focusing on dermatological presentations that you see in GP. These tend to be kind of just single one-off SBAs per condition. You know, big topics like psoriasis or melanoma, there's multiple facts you need to learn, whereas some of the ones we're going to cover today, there's just one or two facts that you need to just commit to memory and be able to reel off in the exam. So I figured it's best to just go through a load of different conditions today. So for those who haven't used BiteMedicine before, we don't just do webinars, we also have a website where you can use our multi-step question bank. So this is basically a case-based presentation where you work through diagnosis, investigation, management, and eventually covering things like pathology and therapeutics. We also have an associated online textbook to go with it. So as I say, we'll be covering the common GP dermatology presentations, focus on how to diagnose and how to manage, and at the end we'll cover a couple of top decile SBAs as well. So I'm aiming to keep this under an hour for your benefit and mine. And for those who haven't been to a BiteMedicine webinar before, we do use menti.com to basically as a question and answer service. So if you hop onto either your phone or a laptop and type in menti.com and put in this code here, which is 4905162. So I'll just put that in the chat. And yeah, you'll be able to play along in the sort of style of a quiz as we go. 4905162. So before we kick off, I really enjoyed learning derm at medical school. I thought it was a really interesting topic. And the way I used to kind of divide my structure would be as follows. So the emergencies, so things like eczema, herpeticum, necrotizing fasciitis, itchy, scaly skin, things like seborrhoeic dermatitis, psoriasis, inflamed skin, dermatitis, eczema, blistered skin, that's pemphigoid, vulgaris, Stevens-Johnson syndrome, things like that, and then pustules, acne, purpura, some of the rare vasculitic rashes and that sort of thing. Tumors kind of covers not only things like neurofibromatosis, but also all of your kind of skin cancers, melanoma, etc. Vascular abnormalities, things like port wine stain and the congenital diseases that you get those with. Hair and nail falls under dermatology. So, sometimes hair and nail abnormalities can be a manifestation of systemic disease. And general skin manifestations of internal disease as well, things like acanthosis, nigricans, and then all the weird and wonderful paraneoplastic syndromes that you get from having a cancer that manifests in skin form. So the slides are available to download on our website, and I think if you're new to dermatology, this might be a nice way to structure your revision. And of course, pediatric as well. The reason it's important is up to 30% of GP consultations are thought to have some element of dermatology to them, so it's a really critical area to be hot on. And I'm currently on an A&E rotation at the moment, and finding it, it's popping up all the time, and being able to reassure patients or just be able to, have good practice with how to deal with these consultations is important. And particularly, using resources like Mind the Gap that, don't just showcase how these diseases are on white skin, but also non-white skin, is really crucial when you're dealing with an ethnically diverse population. So, kicking straight into it then, we've got our first SBA of the day. So, a 26-year-old woman presents to her GP with concerns of a pustular rash across her chest and back. This began 3 weeks ago and has continued to get worse. She has a background of anxiety and asthma, for which she was recently admitted to hospital for an acute exacerbation. On examination, she has numerous pustules in the interscapular region, as well as across her upper chest. So, the question is, and we'll be going to Menti shortly, given the likely diagnosis, which is the most appropriate management option? And here we've got benzoyl peroxide, hydrocortisone cream, oral isotretinoin, topical doxycycline, and topical retinoids. So if we move over to our quiz, and I'll give you guys just a few moments to vote, and also just to get your Menti set up. So this is a two-step SBA. So what that means is it's relying on you first to recognize the diagnosis and then answer the question associated with it. These are common to appear in your finals exams, and it's just a way of them being able to test your knowledge more thoroughly, and for the price of just one SBA. So, given that presentation, what's the diagnosis, and therefore what is the most appropriate management option? Benzoyl peroxide, hydrocortisone cream, oral isotretinoin, topical doxycycline, or topical retinoids. So let's see what people are voting. Okay, so we've got a bit of an even spread here, and we've got currently the majority are leaning somewhere between benzoyl peroxide and topical retinoids. So this is a bit of a naughty question. So the answer is topical retinoids. And we're going to quickly work through now why that is the case. So benzoyl peroxide is used in first-line management. However, it is an adjunct. Okay, so you give it alongside one of the first-line management options. In the case of the diagnosis, this is a diagnosis of acne vulgaris. Okay, this classic pustular rash. In this case, it is appearing across the chest and also in the interscapular region. Now, if we're looking at the correct answer, what you can give to treat acne vulgaris in the first line is a topical retinoid. Okay, so it's like a vitamin A analog. You can give that with or without benzoyl peroxide. Or you can give a topical antibiotic, that being a tetracycline, a macrolide, a topical macrolide like clindamycin. Now, if you give the topical clindamycin, you should also give the benzoyl peroxide. So it's easier to just give topical retinoids. So that's why benzoyl peroxide is incorrect, because you wouldn't just give it on its own. Hydrocortisone has no place for treating acne vulgaris. The oral isotretinoin, that is very much right towards the end of the management when you've kind of ruled out some of the other things. And topical doxycycline is not a first-line option for acne vulgaris. So just thinking a little bit more about that case. So she was slightly outside the age window that we would expect to see in acne vulgaris. So beyond the age of 25, we tend to see it in females more than males, if it's going to present. The clue here was actually that this patient had an asthma exacerbation recently in hospital, and so would have likely have been given some oral steroids for that, and steroids can be a precipitant of acne in later presentations. So there was the clue there. But well done to those of you who got it. So quick chat about acne vulgaris. So it's essentially due to follicular epidermal hyperproliferation. So the skin cells within the follicles proliferate. Multiple reasons why. Combination of genes and environment, but it's crucial to say it's not linked to diet. Okay, there's been a number of studies that have looked into this. So in terms of those who are having consultations about acne vulgaris, it's important to stress that, just because someone, is eating a lot of takeaways, it might actually not be linked to that. So when you get that proliferation, you get blockage of the follicles by sebum, it's an oily substance, as well as keratin. This can lead to a colonization by a bacteria called P. acnes, leading to inflammation of those follicles. And as a result, you get a number of different lesions that we divide into inflammatory versus non-inflammatory. So the non-inflammatory is like the blackheads and the whiteheads, and then the inflammatory lesion tends to be larger papules and pustules, possible come out, as well as larger cysts and nodules. So it's important to say for first-line management then, we're going for a topical retinoid with or without benzoyl peroxide, or a topical macrolide with benzoyl peroxide. There's also scope to give topical azelaic acid, and then it's just important to be doing the holistic care, so giving good skin hygiene advice, screening for mental health concerns. So a lot of teenagers that come in with acne will also have possible mental health concerns, either linked to the fact that they've got their acne or just in general. And then, as I say, important to dispel myths like things about diet. So this is just some images of acne vulgaris on various types of skin. So going on to SBA2, this is again linked to the condition covered so far. So a 15-year-old girl is brought to the GP by her mother due to worsening acne. At an appointment 3 months ago, the girl was prescribed topical clindamycin with topical benzoyl peroxide. However, this appears to have had little effect. She has a past medical history of depression and factor V Leiden. On examination, she has numerous comedones and pustules in the T-zone of her forehead. The question is, which is the most appropriate next step in management? So I'm just going to tee up our mentee again. So which is the most appropriate next step for the management of this patient? We've got azelaic acid, combined oral contraceptive pill, oral clindamycin, oral doxycycline, and oral isotretinoin. I'll just give you guys a few more minutes to vote. Okay, let's see which way you guys are going. Okay, wow. Okay, so proper split mix here. So the answer is oral doxycycline. Okay, so let's have a chat about why that is and why the majority is not correct. So, azelaic acid, we said, was one of the first-line options. This patient's already failed on a first-line option. Now, the combined oral contraceptive pill would have been a correct answer. However, the option of choice usually for combined oral contraceptive pill in acne is a medication called Dianet. It's troside-prindiol. However, this patient had a past medical history of factor V Leiden, a prothrombotic disorder. That would cause a contraindication for the oral contraceptive pill. Oral clindamycin, not an option. So we said it's topical clindamycin in first line, and actually we can use oral erythromycin as a second line if the patient's pregnant. The mainstay of oral antibiotics in second-line management of acne is actually the tetracycline group, so oral doxycycline, which is why this is the correct answer. And once again, we've already mentioned oral isotretinoin is third-line management. So a bit of a sneaky one there, but essentially the important things to take away: combined oral contraceptive pill is a second-line management option, but make sure to screen that question looking for contraindications. Then the alternative would have been oral doxycycline. So well done to those of you who got that one right. So brief summary here, we've said oral tetracycline or an oral contraceptive pill. And third line management, it's important to know that this is prescribed only by specialists, so you have to refer to a dermatologist to prescribe this. So you might hear it called Roaccutane. It's a vitamin A analog. Side effects of it, it's teratogenic, so the practice or the specialist that prescribes it will give you important advice about appropriate contraception. It can cause depression and suicidality, so it's important to screen for that. It can cause abnormal LFTs, and particularly it can cause very, very dry skin, sort of peeling of the skin, which can be quite bothersome for some people, but is part of that therapeutic effect. So, moving on, we've got SBA number 3. A 48-year-old woman presents to her GP with concerns about redness and pustules across her cheeks. She said the skin changes began 2 months ago when she started her new job and have continued to worsen. She takes amlodipine for hypertension, and on examination she has telangiectasia on her nose and cheeks, as well as numerous pustules spread across her cheeks and forehead. So a number of different features here. We've got some redness, some telangiectasia, and some pustules. Question is, a two-step, given the likely diagnosis, which is the most appropriate management option? So I'll just set up the Menti again for the next question, so you guys can begin voting, and then we can go through the options. So, given the likely diagnosis, which is the most appropriate management option? We've got prescribe oral oxytetracycline for 12 weeks, prescribe topical brimonidine 0.5% gel for 9 weeks, prescribe topical hydrocortisone cream for 2 weeks, and oral oxytetracycline for 12 weeks, prescribe topical metronidazole gel for 9 weeks, or a routine referral to dermatology. Bit of a tricky one here. So let's have a look at what you guys are voting. Alrighty. Again, pretty even split. Pleased to see my questions are a little bit harder than my session on personality disorders. The answer is prescribe oral oxytetracycline for 12 weeks. So let's have a look at why this is the case. So it's important to note here that you need to know how to recognize a severe versus a mild acne rosacea. If there is present papules, pustules, or plaques, it falls under the moderate to severe category. And therefore, it would warrant treatment with oral antibiotics, particularly either a macrolide or a tetracycline. Now, I have to hand it to you. The majority of you there went for option D, prescribing topical metronidazole gel. I'm still going to say well done, because that is the correct first-line management option for a mild acne rosacea. So it's important to know the difference. So when keeping acne rosacea in mind, and we'll have a bit of a chat about the signs and symptoms of that in a second, topical metronidazole gel for mild cases, oral oxytetracycline for severe cases. Now, if the patient comes and they've just got flushing features with minimal papules or telangiectasia, you can give this topical brimonidine gel. And this would be a very, very difficult question if this was the correct answer. It would be unlikely to expect this even in finals, to be honest. But, you know, for those of you who want to shoot above and beyond, it's good to know about. It's important to know that hydrocortisone creams can actually flare up acne rosacea. So if you ever see that in the option, it's always going to be wrong. And a routine referral to dermatology is only really done if you're failing on your first-line management options. So what is acne rosacea? Essentially, chronic, relapsing, remitting, inflammatory disorder of your hair follicles and blood vessels. Hence, with the hair follicles, why you get the papules and the pustules, as well as, you know, going on to plaques. And the blood vessels, that's why you get your telangiectasia and your flushing. We've already covered the management with the mild and moderate. Now, one important thing to say is you need to encourage your patients to stop any vasoactive medications. So you might see in the stem of the question the patient being on, in this case, a calcium channel blocker like amlodipine, so you might want to switch that. They can sometimes be a male that comes in, they're on sildenafil, stop that. So just these things to bear in mind. And then obviously, well, not obviously, but the classic precipitants of acne rosacea tend to be some alcohol stress. So in the stem of the question, the patient might have a stressful sort of trigger, or have just come back from holiday with a flare-up. In terms of associated conditions you get with acne rosacea, it's really important to know about the rhinophyma, which I've got a picture of on the next slide. Basically, an enlarged nose, and also you get some ocular features like keratoconjunctivitis, as well as blepharitis, inflammation of the eyelids. So here we've got, I've been trying to work out if this is actually the same gentleman, just a few years apart. I'm not entirely sure. But here we've got some classic sort of flushing, possible telangiectasia on the left, and then the rhinophyma on the right. That's a swollen, sort of bumpy looking nose, but they can get really, really big. So that was acne rosacea. Next up, we have a 21-year-old man sees his GP about a bothersome, itchy rash on his face. He says it comes and goes, but got worse during Freshers' Week at his university. He also complains of uncontrollable dandruff and scalp issues. On examination, there is an erythematous rash on his cheeks and in the nasolabial folds, and there is some scale covering the erythema. So we've got another two-step question. We like to push. Two-step question is, given the likely diagnosis, which of the following is also likely to be present? The options are blepharitis, HIV-positive blood status, resting tremor, rhinophyma, and otitis media. Given the likely diagnosis, which of the following is also likely to be present? So let's see where you guys are voting. Okay, so we've got majority going for blepharitis, 7 votes. It is the correct answer. Well done, majority. Well done. So let's talk through. So the likely diagnosis in this case is seborrheic dermatitis. So these are like classical features of the nasolabial erythema with overlying scale, as well as spreading out to the cheeks, and also, in the hairline, causing dandruff. Now, the commonly associated problems that you get with seborrheic dermatitis are 2: blepharitis and otitis externa. Okay, now, so the otitis media was an option here, that would be incorrect. Otitis externa is correct. Rhinophyma, we've said, is linked to acne rosacea, not sebderm. Now, the reason I put HIV-positive blood status and resting tremor here is both HIV and Parkinson's disease are deemed to be risk factors and associations with seborrheic dermatitis. However, it would be far more common to have blepharitis with seborrheic dermatitis in the wider population than for a 21-year-old with sebderm to be assumed to have HIV or Parkinson's disease. So that's why blepharitis is the most correct answer in this setting. So sebderm, very common. Essentially, it's a chronic dermatitis. We all have this fungus on our face and the skin called malacezia. There's a number of different species, and it's thought that a certain subset of the population develop this hypersensitivity reaction to it, causing this dermatitis of the skin. We've already covered the features: itchy, dry flaking, in the bridge of the nose, nasolabial folds, worsened by alcohol stress and winter. So in this case, it was worse during Freshers' Week. We potentially assume that some alcohol or stress involved. Now, in terms of management, important things are essentially an antifungal as a first line. So ketoconazole shampoo at Nizoral. You can also use zinc pyrothone, which is in a number of different anti-dandruff branded shampoos. On the face, if you're struggling with the antifungal, you can also trial a steroid, mild steroid topical form. And we've covered the associations. Now, in terms of how it looks, I struggled to get some pictures online that did it justice, that were free for use. However, it turns out I have seborrheic dermatitis. I was diagnosed with it a couple of years ago. If you'll excuse the horrendous lockdown goatee, you can see here, both on the left and the right, you've got that sort of classic distribution, sort of in the nasolabial fold, across the cheeks. So, I can fully vouch that the ketoconazole shampoo does wonders for this condition. The issue is that it can dry your skin out quite a lot. So if you're ever seeing this in GP and or in secondary care, it's important to say that emollients can help with that dry skin, but the knock-on effect is that emollients can actually act as a breeding ground for the fungus. So you fall into this sort of catch-22 situation where you're having to use the fungal cream or fungal shampoo, and then So, halfway through now, it's about 7:25, so we're making excellent time. So the next question is, a 19-year-old man presents to his GP with an itchy rash over his trunk. He describes multiple oval-shaped lesions across his abdomen and chest with overlying scale. He first noticed a single lesion several weeks ago. However, in the last few days, many more have erupted over his torso. An examination revealed the following. My question is, simple one, which is the most likely diagnosis? Again, we're heading over to Menti. Which is the most likely diagnosis from that case, with that picture, are options being discoid eczema, guttate psoriasis, Pityriasis rosea, Pityriasis versicolor, and tinea corporis. And just while you guys vote, someone's asked a question about has there been an increase in the prevalence of sebderm due to having to wear face masks during the COVID era? This will be an N=1 answer, I'm afraid, which is myself. And essentially, I can say that I haven't had any issues. Yeah. Okay, so let's see where the votes are going. Okay, so we've got a majority either going for discoid eczema or Pityriasis rosea. The majority wins. Well done. So that's Pityriasis rosea. So let's work through systematically. Discoid eczema, although oval in shape, like we saw in those images, these tend to result in itchy blisters that ooze, and there tends to be a background of eczema. So that's incorrect. Guttate psoriasis can be sometimes confused with Pityriasis rosea. What you expect to see is the same kind of truncal distribution, and potentially on the upper limbs. You get these, what they describe as teardrop-like lesions. They essentially look like mini psoriatic lesions. They can be confused with psoriasis. The distinction here is not only the papular itchy rash on the trunk, but the presence of a herald patch. So essentially, a single patch comes first with Pityriasis rosea, followed later by multiple more. It's actually quite a rare diagnosis, but you may see it. Pityriasis versicolor, although it sounds similar, is a completely different diagnosis, and we will cover it shortly. And tinea corporis, again, can be a bit of a distractor here. Fungal infection of the body causing multiple itchy oval lesions, but again, you'd expect this to occur at the same time, and also tends to be on the limbs rather than the trunk. So Pityriasis rosea, here's a nice close-up image of it. It's unclear exactly how it comes about. It's thought there's potential links to human herpes virus 6 and 7. But essentially, key features, herald patch, followed by widespread papular rash and an overlying scale, as you can see on the right here. Sometimes it might be preceded by a viral or a respiratory tract infection. So sometimes in the case, it might say, they've been unwell with a sore throat for a couple of weeks, and then it came on. That can also be the case for guttate psoriasis, which, if you see it, therefore don't just assume it's Pityriasis rosea. In terms of management, reassure the patient, say it will go away on its own. You can treat the itch and treat the symptoms if you need to. Offer them emollient moisturizers, steroids if it's really bad, or just antihistamines. But other than that, if you just said leave it alone, it will eventually. That's Pityriasis rosea. Also worth mentioning now, Pityriasis versicolor. So this is due to a fungal overgrowth. Again, malassezia. We saw it earlier with seborrhoeic dermatitis. This time it is the fur species, and essentially it can overgrow in warm environments, sweating, adolescents, or moisturizers like emollients. I said earlier on with sebderm, if you use too much emollients, encourage that fungal growth. You can see it here. And with Pityriasis versicolor, essentially you get flaking and hypopigmentation of the skin, particularly on the back or the chest. So we've got a nice image here. You can see this hypopigmentation. Important things to say is it does respond to ketoconazole shampoo. So, it is treatable. You can also use the cream. If it doesn't respond, you need to consider is this something else. And at that point, you would want to do skin scraping, essentially, just take, surface level, minor biopsy, essentially, and send that off to the laboratory. So that's our Pityriasis rosea versus versicolor. So now we're going to cover SBA 6. Hope you guys are doing well. So we have got a 52-year-old woman who sees her GP about a bothersome rash on her wrists. She describes it as intensely itchy. She also reports a stinging sensation when she drinks water. On examination, she has a violaceous, that just means violet-coloured, flat-topped rash, symmetrically on both wrists. Looking inside her mouth, the GP sees this. So we've got, I think this is the tongue depressor here. This is the back of the mouth to the left. The tongue. This is the back molars. So this is the buccal mucosa. We've got this white discoloration there. So let's go to our question. Which is the most likely diagnosis? So opening up Menti. Our options are Lichen planus, Lichen sclerosis, morphea, Pityriasis rosea, or scabies. That's just a few minutes to answer. So, look at that, landslide. Well done, it's Lichen planus. Well done, very good stuff. So, Lichen planus. So, classically, you get this symmetrical, itchy, violet-coloured rash over the wrists and oral mucosal involvement. So, just quickly going through the others before we go into Lichen planus in more detail. Lichen sclerosis tends to be in very elderly patients. You get these itchy white patches on the genitals and also perianal regions. Can be a precursor that predisposes you to squamous cell carcinomas as well in those areas. Morphea, otherwise known as localized scleroderma, you get inflamed, fibrosed skin on the thighs. Pityriasis rosea, we've already covered, and scabies. Yes, you do get itchy, symmetrical erythematous papules at the wrists. You also get them between the fingers, and it would be very unusual to get oral mucosal involvement. You might expect in the history, in a case like this, that they would mention something about exposure to someone, potentially a new sexual partner, or someone coming home from nursery or something like that. So Lichen planus is the most correct answer. So let's go through it. So unclear etiology, again, a bit like Pityriasis rosea. It's thought to be autoimmune in nature. Features include, now classically you'll hear it, I know the 3 Ps, purple, papular, polygonal. Polygonal just being multiple sides to it, so not necessarily circular. You might get white lines across this rash, and those are called WikiCommons striae. And the common places to get it are the wrists, the elbow creases, and soles of feet. It's classically itchy, and it exhibits something called the Koebner phenomenon. Anyone who's at a laptop right now is happy to use the chat function. Do you want to just quickly stick in the chat what you think the Koebner phenomenon is? No. Oh, here we go. Arises at sites of trauma. Absolutely. Yeah. So wherever you have a site of trauma, you get the skin manifestation, commonly seen in Lichen planus and also psoriasis. So you tend, in about half of cases, you'll get some oral mucosal involvement, that white lace that we saw over the buccal mucosa, and can also present as a weird stinging sensation when you drink water. In terms of nail findings, you get thinning of the nails and also longitudinal ridges. You treat with topical steroids, like clobetasol. Now, the reason I've got the sun icon here is when I was learning my steroids finals, I used to find it quite difficult to know which was the most potent. So hydrocortisone, we've all heard of it, fairly common, therefore fairly mild. And then the two that I used to get confused were clobetasone and clobetasol. The way I remember it is clobetasol, SOL is, sol is sun, Spanish sun. Sun is the hottest thing, therefore is the most potent. So clobetasol is more potent than clobetasone and betamethasone and all the zones, essentially. So that's how I remember that. You can also give a mouthwash if necessary, and in severe cases, oral steroids. And the fact that it responds to that probably adds fuel to the fire of this being an autoimmune condition. So that's Lichen planus. So, a couple more SBAs to go. Hope you guys are still with me. So this time we've got a 76-year-old male reviewed at his care home by a visiting GP. The care staff are concerned by a new rash that has developed on his torso and his limbs. He's unable to tell you much about it due to a past medical history of dementia. On examination, he has 10+ tense, fluid-filled blisters on his chest and in the flexural regions of his upper limbs. He has no oral mucosal involvement. Given the likely diagnosis, 2 steps. Given the likely diagnosis, antibodies against which of the following proteins may be present? So let's shoot over to our Menti. So the options are BP130, BP180, desmoglein 1, desmoglein 3, and hemidesmoglein. Guys, just a few moments to think through this one. Ooh, okay. Bit of a spread here. 444. So, last minute chance to change your answer. Sticking. Correct answer is BP180. So let's head back to our slides and have a look why this is correct. So, this is a diagnosis of bullous pemphigoid. I'm sure the whole way through the vignette, the majority of you were going, it's bullous pemphigoid, it's bullous pemphigoid. I know this. And of course, blindsided by the question about the antibodies. So essentially, BP180 and BP230 are hemidesmosomal proteins. So they're involved in the interconnections of our cells, particularly in the dermis. And they're targeted by antibodies for bullous pemphigoid, causing this kind of skin to separate, and that's why you get those tense fluid-filled blisters. Desmoglein 1 and desmoglein 3 are those that are seen in Pemphigus vulgaris, not bullous pemphigoid. They're desmosomal proteins. BP130 is not linked to hemidesmosomes, not even sure if it exists. And hemidesmoglein definitely doesn't exist. I made it up. So BP180 is the correct answer there. Bullous pemphigoid. This is how it looks. You can see these tense fluid-filled blisters here. We've already said the autoantibodies tends to occur in elderly patients, itchy blisters, red skin. You can have an urticarial-like rash. The key thing to mention here is for the purpose of your exams, patients will not have oral mucosal involvement. In truth, up to half of them can, which is really unhelpful as to why we're teaching this otherwise. But for the purpose of your exams, classically in the textbooks, bullous pemphigoid, as a means of differentiating it from Pemphigus vulgaris, does not have oral mucosal involvement. And the management is giving oral corticosteroids. So essentially, it's a bit of an autoimmune reaction, so it gives steroids. The SBA 8, 64-year-old woman presents with severe mucosal ulceration associated with the development of blistering lesions over her torso and arms. On examination, the blisters are flaccid and easily ruptured when touched. Given the likely diagnosis, which is the most appropriate management option? we've got oral clindamycin, oral corticosteroids, oral fluclox, topical corticosteroids, topical fusidic acids. Let's head over to Menti. So, given the likely diagnosis, which is the most appropriate management option? Yet? Oral clindamycin, oral steroids, oral fluclox, topical steroids, or topical fusidic acid. Okay. Let's see where people are voting. Okay. Majority going for the oral corticosteroids. You're absolutely correct. Well done. Yeah. So this is a diagnosis of Pemphigus vulgaris this time. So just going back to the question she's got, mucosal ulceration, blistering lesions, they're flaccid, so they've clearly burst, and they easily rupture or burst when you touch them. This is Pemphigus vulgaris, and just like its twin Bullous pemphigoid, you give steroids for it. You would consider giving oral antibiotics if they develop a superimposed bacterial infection, which is possible, but the mainstay of treatment here would be steroids. You can use a topical steroid as well, but the oral steroid is the most appropriate option. So here's an example of it. Comparing it back to that Bullous pemphigoid image we had before, you can't see these tense fluid vistas because they burst here. Quite an unsightly rash. Autoantibodies this time against desmoglein 1 and desmoglein 3. Those are our desmosomal proteins also involved in the interconnection of cells. Follows a relapsing remitting course, and you get acantholysis in the lower epidermis on biopsy. Acantholysis essentially means the separation of skin cells due to the loss of your interconnection proteins like desmosomes and hemidesmosomes. It's seen quite commonly in Ashkenazi Jews. So if you see that particular population mentioned in the question with the skin conditions, it might point you towards Pemphigus vulgaris. And we've already talked about the features. Nikolsky sign, you see this in a number of different things like SJS as well, but essentially lateral pressure applied to the skin causing separation of the dermis and the epidermis is Nikolsky's sign. And you guys got it right, managed with oral corticosteroids. So fantastic. We've got, I think, one more question and then the top decile question after that. So we're almost home and dry. It's only 7:40, so well done for sticking with me for this long. So a 30-year-old woman, this one's a toughie. A 30-year-old woman presents to her GP with a pruritic skin rash. She states that it began several weeks ago and is extremely itchy. It is affecting her work and her personal life. Examination revealed a mixture of vesicles and papules on the extensor surface of her elbows, knees, and on her buttocks. Given the likely diagnosis, which of the following is true? So, our options. Lesions are caused by Sarcoptes scabiei. Histology from a renal biopsy will show mesangial hypercellularity. Histology from a skin biopsy will show acanthosis and parakeratosis. Immunofluorescence of a skin biopsy will show IgA deposition in the dermal layer. Lesions can be triggered through trauma to the skin area. I'll leave this one up just a little bit longer because it is a tricky one. Okay. Let's see. Oh, not tricky enough, clearly. Well done, guys. Yeah, correct answer is immunofluorescence of a skin biopsy will show IgA deposition in the dermal layer. Fantastic stuff. So let's have a chat about what each of these actually means. So, Lesions caused by Sarcoptes scabiei would be lesions caused by scabies. We've already had a brief chat when discussing Lichen planus that you would get these symmetrical pruritic papules and a history of infestation. So that's incorrect, because in this case you've got this extensor papular rash on the buttocks and extensor surfaces. Classically, Henoch-Schonlein purpura causes a purpuric rash on extensor surfaces. So if you hear in the presentation about extensor surfaces, HSP should be a potential differential. It wasn't that vesicular, but in the case it was. However, if you were thinking that potentially this is HSP, then what you can sometimes expect to see on a renal biopsy is mesophalangeal hypercellularity because of that sort of vasculitic change that you get in HSP, where you've got the purpuric rash on the legs as well as the renal changes. So it wasn't HSP. The histology from a skin biopsy that shows acanthosis and parakeratosis is classical for chronic plaque psoriasis. So acanthosis essentially just means kind of overgrowth of the skin cells, so thickening, a bit like you see acanthosis nigricans, that sort of hyperplasia of the skin. But this is not a typical presentation of chronic plaque psoriasis being vesicular in nature and the buttocks, though chronic plaque psoriasis will affect extensor surfaces. So the correct diagnosis is actually dermatitis herpetiformis. Okay, so if you see the term vesicles or vesicular rash on extensor surfaces and buttocks, dermatitis herpetiformis should be a potential differential. Now, the key features of it are that you get a IgA deposition in the dermal layer. We'll have a bit more of a chat about dermatitis herpetiformis on the next slide. And finally, that lesions can be triggered through trauma to the skin area. That describes the Kerber phenomenon that we've already discussed, which tends to be seen in psoriasis and Lichen planus, not in dermatitis herpetiformis. So it was a tricky one, but clearly not tricky enough for you guys. So dermatitis herpetiformis, the classical association you will think of when you hear it is with celiac disease, which is also linked to an IgA pathology. In dermatitis herpetiformis, you do get IgA deposition in the dermal layer, causing vesicle and papule formation, particularly in the extensor surfaces, the knees, your elbows, and the buttocks. Can get it on the abdomen too, which is what we see here. So you see lots of tiny little vesicles. And something that's always stayed with me from a bothersome SBA that I got wrong in maybe my 4th or 5th year at university is the management for dermatitis herpetiformis, which is dapsone. Dapsone is the correct answer to that, and of course encouraging a gluten-free diet. So that is the end of that part of the webinar. We've now just got two top decile SBAs that are very tricky, I'm hoping, and we'll just quickly go through them now. So we've got a 56-year-old man brought to the emergency department after he was found confused on the streets by the police. His previous admission notes confirm a past medical history of alcoholism and active tuberculosis, for which he has recently started treatment. He claims that he has been compliant with treatment, but has been struggling with the diarrhea side effects. On examination, he has a brown, scaly rash around his neck, as seen on the right here. So the question is, given the likely diagnosis, which vitamin is this patient deficient in? So our options are vitamin B1, vitamin B2, vitamin B3, vitamin B6, and vitamin B12. You might know them as thiamine, riboflavin, niacin or nicotinic acid, pyridoxine, and cyanocobalamin. Okay, so we've got a split. That makes me happy. I worked hard on this question. So that's good. Okay. The correct answer is vitamin B3. Okay, so let's head back and explore why this is most correct answer. So, thiamine deficiency. Yes, you do see it in chronic alcoholism. Causes conditions for beriberi. You've got your wet type and your dry type. The wet being sort of these cardiovascular symptoms that you get. The dry being the more classic one that we all think of with the sort of neurological signs like cognitive deficits. However, it's not the most correct answer. Riboflavin deficiency, scaly scalp, sort of, inflammation in the corner of the mouth, get a description of a magenta mouth or magenta tongue. Vitamin B3, niacin, is the most correct answer here. So this patient is presenting with diarrhea, although he puts it down to his TB medications. Dermatitis, he had that rash across his neck, something called Casals necklace, which we'll see in a second, and confusion. So we tend to think of niacin deficiency as causing the 3 or 4 Ds, diarrhea, dermatitis, and dementia, with the 4th D being depression. And this is a collection of symptoms that together is known as Pellagra. Niacin deficiency, Pellagra. So that's the most correct answer here. Vitamin B6, pyridoxine, classically will cause a peripheral neuropathy. And vitamin B12, again, you get a peripheral neuropathy, and you can also get a macrocytic anemia and a dementia-like presentation. So tricky one there. Niacin deficiency called Pellagra. Next question. Which of the following is likely responsible for this vitamin deficiency in this gentleman? So he said that he recently started active tuberculosis treatment. So that's the final question of the day. Let's make it a good one. Which of the following is likely responsible? Is it ethambutol, isoniazid, pyrazinamide, pyridoxine, or rifampicin? Yeah, it's just a few more moments to vote. Okay. Guys, what a way to finish. Well done. Yes, isoniazid is the most likely responsible agent. So let's just head back and just really go through it. So isoniazid, classically, you will learn for your exam that isoniazid can cause a peripheral neuropathy, and therefore it is really important to give pyridoxine, vitamin B6. Okay, and that is correct. However, isoniazid can also cause vitamin B3 deficiency, however, to a lesser extent. Alcoholism can contribute to niacin deficiency, so the presence of alcoholism plus his isoniazid use likely leading to his niacin deficiency and thus Pellagra features. So just a quick summary of Pellagra. Here we've got the Casals necklace, dermatitis presentation, caused by niacin or vitamin B3, seen in alcoholics with malnutrition, exacerbated by isoniazid, and we've got our 3Ds, dermatitis, diarrhea, dementia. It's brown, scaly rash, sun-exposed areas, and the management is vitamin replacement. So that brings us to the end of the webinar. Thank you guys so much for tuning in. It's really, really good turnout today, and thank you for playing along with the quiz. Any questions, please don't hesitate to tweet me, email me, get in touch with BiteMedicine through our email or Instagram. And if you like the way we do our sessions and you want to find out a little bit more about our website, please do check it out. And if you wanted to upgrade to a premium account, you can use my discount code 20% off, Richard2021.